Good morning, everybody. Welcome back to part three of motivational interviewing. This is our third and final session. And so we're pretty excited to kind of finish this up, have some good conversation today, and maybe some thoughts or plans of how to move forward with using motivational interviewing where you practice. So I'm going to hand it over to Marilyn.
Thank you, Sue. And thanks so much again, Terry, as well, for all your help. And yes, this is day three. And I'm super excited for this session because I hope that it will all kind of come together as well as give you some really practical tools like those little starred slides that you can use as almost like a loose script for practicing with clients, patients, like this afternoon, if you want. So, and we'll have some time for discussion. It was great discussion last time. Thank you, colleagues, for throwing things in the chat and for your engagement. I really appreciated those of you who shared some of the current clinical challenges that you have, the questions that you have. And I hope we have more of that today as we're kind of going to make the most of our precious hour and a half. And thank you again for taking your time out of your busy day and on this beautiful winter day in Ontario, and certainly a very wintry day in Toronto specifically. I want to acknowledge that I'm joining today from Treaty 13 and the Williams Treaties, as well as unceded lands that continue to be contested, and encourage you to consider the traditional lands and territories that you're joining from today. So, like we've done the last couple of times, why don't we start with a polling question? So, Sue, if you could throw up our polling question for this morning. So, what is your current mood? And we have four choices this time: alert and curious, stressed out, kind of grumpy, or happy as a clam. I don't know where that expression came from, happy as a clam. I guess they look like they're smiling. So you can vote. How are you? What is your current mood? I wish we had emojis that you could put in as well. Feel free to put an emoji in the chat if you want to see. So let's see how we're feeling. What is my current mood? My current mood is I'm kind of feeling happy as a clam this morning, even though I haven't shoveled yet, which that actually it's going to be fine. It's good exercise. That'll be my workout for today. So let's see how we're doing. Okay, so we have a few happy as a clam, good, alert and curious, and yes, stressed out. But it's Thursday and tomorrow's Friday before the long weekend. And yes, kind of grumpy. I also have those days. So I hope that after today, and well, certainly by Friday afternoon, I think we'll all be happy as a clam, as little clams, getting ready for a well-deserved 3-day weekend, family day weekend. So, colleagues, I'm going to throw up my slides. And actually, I took a picture last night. I was downtown with my daughter. We met for dinner and a lecture. She's like an art person. So I went to a lecture at the art gallery. And on my way home, it was so beautiful. It was like this gorgeous, quiet, like there was no traffic, albeit I had to wait at the subway for 15 or 20 minutes for a train to come. But I hope that you're also enjoying peaceful winter nights and beautiful winter days. I hear it's sunny there, which is amazing. I think the sun just came out. So welcome to our third webinar. And I'm just going to see if I can minimize this. There we go. Okay, so here we go. Webinar number 3, February 13th, 2025. So here we are, tools for working with complex patients. And as I said, I hope that this really ties together some of the themes and techniques and the spirit of motivational interviewing, very important, that underlies all that we do, a way of being with our patients, our clients. So I'm going to do a very super fast lightning review and welcome if there's anyone joining for the first time. So we're not going to redo the first two webinars, but just to refresh and reorient ourselves, as well as orient anyone who's just joining. So in webinar one, we really laid the groundwork of the core skills of motivational interviewing as underpinned by the spirit of MI. Those four foundation skills are ORs, as well as the four key tasks, which we're going to dig into more today. And last time, just 2 days ago, we focused on change talk. Change talk predicts outcome. Change talk predicts whether someone is going to actually change. So it's really important. And thank you for participating in the fun quiz we had of Spot the Change Talk. I really saw that we do recognize change talk when we hear it. And then we talked further about how we respond to it and how we invite it. So always important that all of this work we come to with that spirit of motivational interviewing, partnership, equal experts, that absolute worth, autonomy, accurate empathy, and compassion. We are in service to the other and are supporting people realizing, evoking their own strengths and abilities. And there's an axiom in motivational interviewing called evoke versus educate. In other words, better for the patient to be articulating the things that we would like to say to them, if possible. Now, they're not going to say everything because we have lots to share. And today, guess what? We're going to talk about how to share information in a motivational way. So evoking, we talked about using our ORs, directional questions, affirmations, directional reflections, and directional summaries. And the homework was a template for how to have a short conversation, actually using all of those skills. So that idea of going in the direction of change talk and de-emphasizing sustained talk. And we looked at some patient examples of things that they would say, how we might respond using the motivational interviewing skills. And remember that those kinds of change talk, preparatory change talk, desire, ability, reasons, and need, and mobilizing change talk, commitment, activation, and taking steps. And that change talk and sustained talk are two sides of the same coin. Ambivalence is normal. Sustained talk is normal. And that what we reflect, that's what we'll hear more of. So if we focus and reflect and discuss sustained talk, we're going to hear more sustained talk. And that's not helpful in enhancing motivation for change. If we reflect, if we go in the direction of change talk, that's what we will hear more of. And we also talked about these scaling questions as potentially quite helpful in evoking change talk and kind of assessing where that person is at with respect to importance and confidence to change, because importance plus confidence equals readiness for change. So over the last 48 hours, did anyone have a chance to practice the homework? Would anyone like to share if you did the homework? I didn't do a polling question about it because I know it's getting short. So I'll just give a moment if anyone did have a conversation. Not hearing anything. I know this was a very short turnaround for practice, but I do want to highlight this slide because this is very much a conversational template that you can use to evoke change talk from your patients. And if you feel stuck, oftentimes this is my go-to. Why is this important? Like, why would you want to make this change? And how could you go about it in order to succeed? Oh, Saudia, do you have your hand up? Do you want to unmute and jump in?
I do. So this is more of like a, so the situation that kind of came up, it wasn't exactly this sort of, so we were talking about goals, what the client wanted to achieve, and their goal that they had in mind wasn't exactly the goal that I had in mind. And that's where it was a little bit challenging, because you do want to go with so there is change. It's like, I need this, I need to work on, I don't want to do too much in terms of PHI, but like, I need to do X. And I'm sort of like, but do we need to do X if you do A and C?
Yes. So
And
how did you handle that when, and I sense that that's not uncommon. I'm
it's
sure there
not.
are lots of people that are experiencing the same thing.
Yeah, so it was challenging because you want to go with like I want non-judgmental, really trying to be open to, okay, well, why do you want to make this change, and what can we do to help you succeed, and they have it in their mind how that looks for them. And I think I need a little bit more context here. So it's essentially like, they want this particular piece of equipment or whatnot, but the part of the issue is some medical issues that need to be dealt with first, and beyond my role. So it's a little bit, you know,
I
can you?
love your example. And actually, that is a perfect segue into one of the tools that we're going to talk about today,
Perfect.
where the client comes with quite a clear direction of what they want to do, but there are some pretty compelling reasons why that might not be the best way to proceed. And yet, at the end of the day, they will do or not do like what
Right.
we tried, right? And so, how do we even have a conversation about that? But
Hmm.
in that spirit of MI. So, I love that you're coming at it from that perspective of trying to balance that non-judgmental acceptance. And yes, patient self-management, it's a thing. But at the same time, we do need to share our advice and information that could
Right.
shape or constrain the choices that they make that relate to, for example, a piece of equipment. So thank you for that, Saudia. In fact, if with your permission, can we come back to that
Sure.
when we
Yeah.
get into
It,
that?
it's very similar to the thought of like stroke, right? Here's someone who continues to smoke after a stroke. So in this case, after if they have issues with skin integrity, but then they continue to not make medical changes to improve their skin integrity, they're going to continue to be at risk. So it's very similar in that same vein of like you're making choices that don't necessarily,
Yeah,
right? And how are we navigating that? So yes, you can come back.
exactly. Love it. Thank you. Thank you for that.
Marilyn,
Yes.
thanks, Sadia. But I also wanted to mention that Sarah put in the chat that she didn't have time, but she's planning to practice with her teenage sons. So there you go.
Yay, Sarah. We're gonna get him to like study for his exams. If in fact, I would love, and my email is on the slides. I would love for any of you, all of you, to drop me a line and let me know how things are going. Or if you have a question, happy to engage. So like connect with me on LinkedIn, connect with me by email, connect with me on Instagram. Not that I'm on Instagram all that often. But yeah, this I would love to continue the conversation. But so thank you for that, Sarah, for your intent. Because, and that's the thing, change is a process, not an event. And holding on to that idea sometimes helps me settle a little bit my fixing reflex, recognizing that it's like that if I create the conditions in which that person is going to want to engage and re-engage with me, then I will have more than one opportunity. But even if I only have that one opportunity, because sometimes we have clients who connect with us never to be seen again, how do we also use that precious time to plant a seed? Because they will be connecting with someone else again. And sometimes we don't get to see the fruits of our labor blossom, like just blossom with someone, the next person that they see. So how do we plant those seeds, even if that change doesn't happen like right on our schedule? And I
Right.
also appreciate that sometimes it's quite like the need is quite immediate. And so it is important for us to share that information so that people are making informed choices. And that's what we do in healthcare, right? It's all about informed consent. When people consent, they are exercising their own power and autonomy over their own life. And so, no matter, and I think COVID was such a great example of that. The number of people who didn't choose to get the vaccine, that was really hard. That was hard to see. People that left jobs after 20 years because they chose not to, some real consequences to that. But the key is, are we providing the information for them to make a decision, whether we agree with it or not? It is their life. So with that said,
Marilyn,
yeah, sorry,
Sarah
go
has
ahead.
also mentioned, which I think is a good point, is that she thinks it needs to happen organically. Her little conversation with her son.
Yeah, and well, let me, can I reframe that a little bit? Ideally, it feels like it happens organically for the patient, for the client or the loved one, but it's almost like we're ducks or swans where we're gliding across the water. It feels like a conversation, but underneath there's a lot of paddling going on. There is a lot of skill and intentionality to it. And that's the practice part. So let's hold on to that, because right at the end, I do want to spend a few minutes talking about sort of next steps, some additional thoughts or ideas for how to practice, because that's really where the true value of the time that we've spent together will come forward. So I think, but the nugget there is that it should feel authentic. It should be authentic, human, engaging, and that's the organic part. That's the part we can't fake. And not that hopefully, well, there's a whole other conversation about imposter syndrome, which I did a TEDx talk about that actually. So, but yes. Okay, so let's talk about tools for working with complex clients. So we're going to focus on focusing. So last time I promised that we would talk about goal setting. And thank you, Sadia, for highlighting this right at the front end. Also, I'm going to share a really helpful conversational strategy for planning, for providing information and advice, your input in a motivational way, in a digestible way. How can they hear it, digest it, understand it, and how can we even amplify that for them, make it even more salient for them? And then we'll talk a little bit about continuing practice and have some time for some wrap up. So I want to start with this quote from a study from back in 2016, which I think is still absolutely relevant. That notion that stroke occurs in isolation in only 6% of stroke survivors, and with an average of 5 other conditions. And I'm sure this resonates for colleagues on this call, where the level of complexity can be quite daunting. The number of different interventions, the number of paths to reach to recovery may feel daunting to you, may feel even more so to your patient. And I'm sure you've experienced that. So where do we focus? How do we focus? How do we make sense of all of the different dimensions of recovery in ways that are experienced as helpful and supportive and also achievable to those patients? And so I mapped out some of these different dimensions of complexity based on the literature. And I mean, it is quite overwhelming looking at both the medical, psychological, behavioral, all of the different social determinants of health. And this particular study didn't name systemic racism and exclusion, but it's important to name that when we think about how that maps on to all of these other factors, including systemic and structural factors in our healthcare system, it's real. And it does have differential impacts for populations and communities who have been historically marginalized. And so with all of these different determinants, where do we start? I think the baseline assumption we can safely make is that all of your patients are complex, no matter where or how they're presenting. And so I want to just give an opportunity. Is there anything that we haven't covered so far that you want to make sure we talk about, so that at the end of these 3 webinars, you feel like this was of real value? And any other pressing or difficult motivational challenges that you're experiencing. So feel free to put something in the chat, or if anyone wants to raise your hand and unmute. This isn't your only chance. We'll have more time for discussion, but I just wanted to pause and give that opportunity.
So while people are typing in the chat, I think I'll reemphasize people with aphasia and the difficulty with communication they have in trying to have this type of conversation with someone that has difficulty either understanding what you're saying or getting out what they're trying to say. So that's
Mhm.
always adds some complexity, and our speech therapists in the group can certainly attest to that.
Thanks, Sue. Yeah, and actually the planning tool may be helpful in that, not sure, but would welcome colleagues' thoughts. And
Anybody else?
it may be that this agenda for this session looks okay to folks. So if there is anything, this
Brooke,
is
go
the
ahead.
Hi there. Um, I don't know if this is the case for anybody else, but for me, when I'm looking at this question of what are your most pressing, difficult motivational challenges with your patients, I've worked with a few patients who had long-standing histories of depression, um, actually a couple with some dementia as well. So the apathy is strong. And I think more than trying to motivate those patients, it's kind of reflecting on, okay, how much can I actually do here? Because I was thinking about how last session you were sharing, these weren't your words, but this was how I processed it. You don't want to work harder than your patient, if that makes sense. I don't know if you agree with that kind of sentiment, but
yes, totally
um,
agree.
yeah, so I don't know if you might be able to kind of speak more to that side of it, that it's not the patient's not really having an issue at all. They're like, yeah, a patient literally said, yeah, I'm in bed all day. I don't mind. It's fine. I like to rest. I have no desire to get out of bed. Okay. And the wife says it's been like this for years. So recognizing how much are we going to do in 8 weeks or whatever it is. Yeah, if you might be able to speak a little more to that, that would be greatly appreciated.
Totally. And I really identify that both clinically, but also on a personal note, because my mother, before she passed away last September, was very fragile, but had no medical reason, like mobility reason, that she could not be up, and eventually was confined to a wheelchair, but it was all about refusing to use her walker, refusing to be mobile, and ultimately at the end, refusing to get out of bed. And it was just so difficult to see that. And the director of care at the residence where she lived said to me, Marilyn, you need to accept that this is how she wants to be right now. And because I had been sort of in this conflict mode, and the times that I spent with her were a little bit conflictual because of the sense of urgency that I felt. And so I wasn't that I ever stopped encouraging her to, get like experience more of the community where she was, but also coming to an acceptance of her autonomy. And I guess reflecting on that, let's talk about how some of these tools could be useful regardless of where a patient is and regardless of the choices they're making. And I think underlining more than anything that spirit of motivational interviewing, that it's not that sense of I know what is best for you is perilous. I know what is best for people with this condition, but you yourself ultimately will make choices based on what you decide is best for you. And that's that paradox that we're holding in balance. So Brooke, thank you for naming that, because I think that's where we are like chasing our tail so often. Like it can be so discouraging and dispiriting. And yet for someone to have that contact with us and feel seen and not judged and accepted and celebrated for who they are, that in itself can be quite curative. And that in itself maintains a relationship, a working alliance, and an engagement that that surprisingly, some people do actually change despite all odds, and others don't. So that's the reality of the sphere in which we're working in. How does that fit
We
for
have a few
you?
more comments if you'd like to hear them.
Love to.
Brooke, did you want to follow up?
I was just going to say really quickly, thank you for that statement of some people change and some people don't. And I think, yeah, just remembering that is important. So thank you for sharing that.
Thanks for raising this. Really resonates for others, I'm sure. Other
Yes, so
comments?
Catherine agrees with Brooke on the apathy piece and states she'd also like to add clients having reluctance to hope because this has been their situation for years. They don't try, they don't risk further disappointment. So even though they may have good goals, they aren't really ready to try. I also have clients who don't leave their home.
Yeah, yeah.
And the second comment is from Krista, and she said from the scenario she mentioned yesterday, she's looking for tips on checking her own attitude before going into an encounter with a patient to have the open-hearted attitude I believe I should have to be useful to them with working on goals together. Perhaps a tip you used for how to start fresh each time and not drag previous past patient behaviors into a current visit to cloud openness.
Oh
And you
my
might have
God.
just answered it, she said.
No, actually, sorry, who shared that?
Krista shared that.
Krista, thank you. Like, there is literally a centering meditation I'm going to share towards the end that Bill Miller includes in his book as a preparation, like a preparatory meditation for motivational interviewing. That might sound kind of odd in this like very evidence-based like it has been manualized in randomized controlled trials, et cetera, intervention. But that's what I find so affirming about motivational interviewing is that it is so human and authentic and real. And it's as much about us as our patients. And so thank you for naming that idea or that aspiration of starting fresh each time and leaving those assumptions aside and offering our undivided attention and positive regard to that person, regardless of their circumstances or their choices, just by virtue of the dignity of being human. And what they consider to be a good life may not be what I consider a good life for them or for myself or my own loved ones. And so, how do we untangle all of that? Because we're human too, and we enter into these very human conversations with all of our own biographies and histories, and they bring theirs too. So, it really is a kind of coming together, and that's quite inspiring too, that notion that each and every opportunity with a new patient or one that you've seen for years, maybe decades, is a new opportunity in and of itself. So I think that's quite uplifting. Thank you for sharing that, colleagues. This is, I think, a beautiful start to an important conversation that I very much hope continues long after webinar 3. So let's focus on focusing. Where are we going? So remember that first underlying task is about engaging, that working alliance. That never goes away. We're always re-engaging with our patients. So it's not like we can just forget about that and move on to focusing. So when we have that trust, that mutual trust, that engagement, how are we going to work together? Where are we going? Because motivational interviewing is not directive. It is directional, though. There are goals. And those goals are goals that we are in alignment with our patient. And so to Saudia's point, well, what happens? How do we actually get to goals that we're aligned on? And in motivational interviewing, there are 3 kinds of scenarios in that focusing task that we can diagnose. So the first one is when the patient comes with straightforward goals. They themselves have a specific goal, and it's one that makes sense. Like it's one that's also clinically indicated, very clear and specific. The other kind is where there's a general goal. There might not be a very clear path of how to accomplish it. So how do we navigate that? And the third kind is where someone comes with just this kind of very vague distress, concern. Where do we go with that? There's kind of no clear goal, even meta goal in mind. So where there are straightforward goals, you're both in agreement. This is a good target physio, a specific set of exercises, or like whatever the target is for your patient and you, there's probably little further focusing needed, but those OR skills could be helpful to get to some of the specific micro steps to achieve that goal. So someone who's saying, I need to get my mobility back. Okay, that's clearly, we're going to focus on mobility. What are some of the specific things? How, and then negotiating how we're going to do that. But that's, I won't say the easiest one because goals change and people don't always follow through. And we'll talk a little bit more about that actually. So, but in terms of actually focusing, collaborating, identifying a goal, that's pretty straightforward. The other one is choosing a path. So this is where someone has a long-term objective. I want to feel productive again. I want my life back. How do I recover from this? It makes sense. These are all very clear, specific endpoints that person wants to get, but we're not sure how to get there. Well, we might be sure, but we haven't yet agreed on a plan with that patient. And so this bubble sheet, has anyone used it? Just feel free to put it in the chat or raise your hand. This is not brand new. It's certainly not new to motivational interviewing, and it's been adapted to different medical and health settings. Actually, patient self-management, I'll put a reference in that in a couple of slides, actually adapted and used this as well. And it's been used in some different studies, research studies too. So this bubble sheet is very visual. So perhaps for someone with expressive aphasia, it might be a helpful tool. You tell me, I'm not sure. Where you can pre-populate it with different dimensions of potential areas to get to that endpoint that person wants to get to come to some alignment around where you and they will agree on specific goals. So here I've mapped out different, we talked about patient complexity and stroke rehabilitation. There are no shortage of different targets. And in fairness, it would take a pretty highly functional type A, fully, cognitively intact, mobile, not traumatized, alert, happy as a clam person to be able to tackle all of these things at once. Can any of us do it? I'm not sure. So where do we start first? Where are we going to go? And that's the conversation. And so here's a little bit of a script for how that could go. Hypothetically, this may be new to you. One thing about stroke rehabilitation is there are lots of different things you can do to support your recovery. Here's a sheet that shows some of them. We've already talked about, say, smoking and medications. Where else would you like to focus? And is there something that's not here? That's what that question mark is for. So it's also inviting the patient's expertise into that conversation. So this may be something that could be helpful, especially if you find that you are at that the goals keep shifting, like you think you're working together on something, but people are coming with other things every session and it's a little bit murky. Or if you're not sure that you are really aligned, like that could be maybe a refocusing conversation. This is the patient self-management resource that I mentioned. It's super robust. It's basically a compendium of a whole bunch of different tools to work with clients and patients for non-physicians as well as physicians. It's not new, but it's aged well. I'd say it's about 15 years old or so. And one of the tools in that is for working with older adults is this bubble sheet. So I highly recommend it. The link is in the slides. And there are lots of good nuggets in there as well. And then in terms of the bubble sheet, I noticed that there is a stroke rehabilitation checklist. I don't know if this is something that you use routinely or patients or their families use routinely, but it struck me that this may be something that could beautifully populate into that bubble sheet, that agenda mapping sheet. So I don't know if anyone has any thoughts about that. Is this something that you could see using, or has anyone already used it with patients? And if so, would love to hear your experience with it.
I can tell you that the post-stroke checklist is from Heart and Stroke and it's free. So people on the call that haven't seen this before, you can order them. It's like a tear-off sheet and you just tear it off for each patient. And it's really target audiences, physicians, nurse practitioners, probably nurses, in follow-up visits after they've had their stroke and they're back home. But it certainly could be utilized in bubble form as well, I would think. Does anyone have any thoughts or comments?
Okay, well, food for thought, and the link's also there in the slides. So in terms of focusing, focusing in on a path to get there, that's perhaps a tool, strategy, way of engaging that could help with that. Now, what happens in the third scenario when patients come to you with no well-defined change goal or options to choose from, but they are in distress, like there is a concern, my life is a mess, I have no hope. Where do you go with that? And that's where I think, although this is a focusing task, it also builds on engaging. And like they all do, right? But that engaging piece, that working alliance, that mutual trust, so important to have these real honest conversations here. And you noticed I starred this. These are some good starter questions to start to get at clarifying what kinds of goals could even be on the table. How would you like things to be different for you? What's worrying you most about where you're at right now? In an ideal world, so that looking forward strategy, what would things look like for you? Where would you like to be? What are you hoping for at this point? And using oars to have the conversation. So you don't like just really reflecting, not necessarily the directional reflections, not even so worried about change talk in this focusing conversation. It's about coming to common goals. And so the evoking, what we talked about last week, is then evoking change talk, motivation for change. Resist the fixing reflex. In all of these planning conversations, focusing conversations, it can be very easy to jump right into planning. Okay, we have a goal. How about this? How about this? So one of the take homes, I hope, from this conversation is that focusing on the goals doesn't necessarily mean that the person is going to leave your office or consultation room and immediately follow through. There may need to be that evoking task, right? Of identifying, like helping them to identify that, drawing out of their own motivation and determination to change, because ultimately they are the ones that are going to have to follow through on this. So remember MI spirit, resist the fixing reflex, and your oars are really the helpful tool to get through those planning conversations. And when your goals differ, then those questions like what are they willing to do? What matters to them? Is that a way into a focusing conversation? What are they motivated to do? Because we're all motivated in some way. As Freud famously said, all human behavior is purposeful. And that's from someone who does cognitive behavioral therapy. So the fact I'm quoting Freud is very notable. And resist the fixing reflex. It bears repeating. So that's like a quick tour of some of the focusing strategies. I'll just pause there in case there's any questions or reflections, anything that you want to think through on that. Or so far, so good.
I feel like I need a little handout,
Yeah.
or of some suggested questions, that could be
Yes.
referring to as we learn to put this into practice.
Well, that was my intent around putting stars on some of the slides, is that I know we're like me, you've probably gone largely paperless, but there are some things that might bear printing out and just having them, or putting a little post-it note on your desk, like some of those things. One of the post-it notes that I had for a really long time was just yes, but, because that reminded me that when I heard a patient say, yes, but that I needed to take a step back, that my fixing reflex got activated. And just that awareness, that self-awareness of that actually helped me kind of go back into a more motivational way of engaging. So you can see sort of how hopefully this is all building together, right? So if we've identified collaborative goals and we've spent a little bit of time working with that person to help them articulate their own reasons for change, which predicts actual change, you can start to get a flavor of when that person is ready for a planning conversation, when we're ready to move from the why to the how. So what are some of those signs that a person is ready to transition to planning? Because that, I can't emphasize enough, that premature default to planning, sometimes before we've even engaged with the person, before there's that working alliance, or as soon as we think there's a goal to work towards, or maybe even before we've agreed on a goal, when we come in with our own goal, we often want to move right to planning. So hopefully this, at least, if nothing else, helps to like just take a step back and diagnose or assess where some of those frustrations or roadblocks that you're running into might be coming from, and how you could come at them in a slightly different way by combining them with other ways that like you're engaging models of practice or ways of engaging with your patients. So what are some of the signs of readiness for change? And these are probably self-evident based on our conversations thus far. So you start hearing more change talk and you start hearing less sustained talk. And there's this feeling of resolve in the person. It's almost intangible, but you have this sense like, I'm doing this. Like, this is important to me. And I feel I can do it. That sense of confidence and competence to do it, and also that this is important. You have both of those ingredients, readiness for change. And people start envisioning the change, and you also start hearing people talk about small steps they've already taken. So those are all signs that it's time to move into a planning conversation. And we're going to use those oars to collaboratively formulate that plan for change, moving from the why to the how. And so this is, and Sadia, you named it, I think, that notion of goal setting, where the patient has one goal and you have another, and how do we navigate this in a way to be very accepting of their goal when actually maybe you're not allowed to use that equipment until you're medically cleared to do so, or maybe it's scaffolded intentionally because there are liability issues for the hospital if I let you do, X and you haven't done Y yet, or shown that you can do Y first. So how do we provide motivational interviewing, information and advice in a motivational way? So I don't know if this is making anyone hungry, or maybe you'll have Thursday night sushi instead of Friday night sushi, but that's one of my favorite foods. So first order of business is get permission. So we always get patient consent before any medical or health related procedure, but we don't always get conversational consent. And we know that talk therapy is very powerful. It is an intervention. And so and that even if we're not doing CBT or DBT or other kinds of psychological or therapeutic treatments, that getting patient conversational consent is never a bad idea. And there's a couple of kinds of consent. One is that it's implied permission or implied consent to have the conversation or for you to share information. So it might be that they ask you a direct question. Obviously, they want you to tell them. So that information is welcome to them. What does my test result mean? You don't need to say, is it okay if I share the results of your test? What do you think I should do? How should I go about this? Those are all signals the person wants your advice. However, a lot of times people do not ask us directly, and we volunteer because that's what we do. We're experts, we're health professionals. So If you're not invited, preface it with a question asking their permission. Can I share a couple of suggestions about this? And or if, for example, in the illustration of the patient who wants to use a piece of equipment that they really shouldn't be using yet, can I tell you a concern I have about X, Y, Z? Or would you be interested in hearing about this? So, and if the person, in the very unlikely event, it's like 1 in 1,000 times, says, no, I'm actually not interested in that, it's usually followed by, because I had a half-hour lecture from my doctor or my nurse practitioner. Like, it may be that someone else has already told them all this information, in which case that opens the door to have a deeper conversation about that. So what did your doctor tell you about XYZ? What's your understanding of it? Can I share some thoughts about that? So there is no downside to asking permission. Plus, it's respectful and it affirms autonomy. So it helps with that engagement too. It feels like we're two equal partners. Like, it really does then feel like a partnership and a conversation. We're in this together. So even when you have permission, though, it is also wise to be explicit about their autonomy, their freedom of choice. And so other things that you can say are like, so they've said, yes, yeah, please share. Sure, I'd be happy. Yeah, I didn't know you had any concerns. Okay, I don't know if this is going to make sense to you, but, or whatever you decide to do, it's totally your call. You may already know blah, blah, blah. Or I wonder what you'd think about this. So these 4 prefaces to sharing information are also super helpful, because what they signal to the patient is, you are in charge. I'm going to share this. I'm an expert, but at the end of the day, it's your responsibility to make this change, which it is, which is no less than the truth. No matter how difficult or disabled, each person all comes, is born with nothing, with one specific thing, and they die with this one specific thing, which is that inner power of themselves. No one can ever take that away. I mean, we've seen that in the most dire of human and historical injustices, that there is an inner dignity and power that we are honoring with this. So I hope this doesn't sound too deep or intense, but there are some really, I think, important metaphysical and humanitarian reasons for engaging with people in this way. And then providing choice. Freedom is about having choices. And this is also I think, one of the recommendations in working with patients with aphasia is providing choices. So in addition to the sushi, I took this picture of this most amazing spaghetti I have ever eaten. I was in Pisa last year, and it was literally like one of the best meals I've, and those are actually truffles, like hunks, like shavings of truffle. I hope, are you getting hungry for lunch? Anyway, the notion is giving choices. If we suggest, and I've done this usually with a loved one or a family member, when my fixing reflex is activated, it's like, so say my daughter is I don't know, trying to decide about some course that she's going to take or something. And it's like, well, have you tried this? Well, what about this? Well, how about this? And by giving them one at a time, she's like, no, that's not going to work. No, that's not going to work. That psychologically, it's more helpful to give, 3 or 4 or 2 or 3 options, and then invite the client's choice. And we can also say, and maybe there's some other avenue that I haven't mentioned that you think might be helpful too. So that's just a little tip in terms of getting out of that question and answer trap, that sort of making suggestions and being shot down, like each suggestion one after the other. People use this in sales, actually, I think. But again, this is offered with as the spirit of motivational interviewing, that very ethical, with integrity, in service to the other, really with the other's interests as paramount. And this quote from Bill Miller and Stephen Rolnick, that information and advice are easier to digest when surrounded by good listening. So here's the kind of way of holding the conversation. So you can ask, and there are some different things you can ask. Is it okay if I suggest a few options? Or would you be interested in hearing more about, or what do you already know about recovery after a stroke? That third question I find is such a helpful one to start with, because it honors that the person comes with information. It may not be accurate, it may not be complete, but that's the information they believe is true. And so it's really important to surface that so that we could at least have a conversation about it. And that if there are some inaccuracies or misconceptions or myths, or that we have a chance to clarify those and correct them. And then we're using our oars for that part of the conversation. And it may be only a minute or two. Like, this whole thing is like 2 or 3 minutes that could cycle through a 10-minute, 12-minute conversation. So we're not talking about a 90-minute therapy session here. I think that's really important for busy clinicians. So reflecting and summarizing. And then offer your information or advice. A little goes a long way, and I'll come back to that. So however much you want to information gush to them, a little goes a long way. And then ask, what do you make of that? How does that fit for you? How would you like to move forward from this? Reflect and summarize. And so you can see that this can go in kind of a cycle, throughout like as a kind of structure for a planning conversation. And so in a nutshell, it could sound like, what's your understanding of XYZ, stroke rehab? Can I share some additional thoughts and information about how you could move forward? How does that fit for you? And it can be really simple. And then we're using reflective listening to further highlight and reflect back to the person what they've said. And so this is from this book called Presentation Zen by Gar Reynolds, who revolutionized my slide decks years and years ago. This is an old book. In fact, I think it might even be in its 3rd edition now. But he lives in Japan, and there's this expression called hara hachi bu, which I don't speak Japanese, but it means eat only until you're 80% full, which is like the healthful way of eating, Japanese eating. And so I think it's actually a really good way of thinking about how we offer information and advice to our patients. That sometimes, maybe oftentimes, speaking for myself, we want to make them like holiday season full, like Thanksgiving full. But in fact, a little goes a long way. So I hope that visual reinforces that. And then the key question, as you've had the conversation, is where would you like to go from here? And that really gets at kind of, so what is that how going to look like for you? So remember that quote from last time, I learn what I believe as I hear myself speak. That this ask, offer, ask template organizes the conversation so that the client, the patient, is saying out loud the information, the advice, the directions, the planning, the change talk, all of the things that we want them to most remember, that we want them to embody, because they're the ones that are going to be making this change. So very important for them to be saying it, not just us saying it. We talked last time, patients remember the least of what we say. So I'm sure you've had the experience where someone's come back to you after a conversation and you're like, yes, and as we discussed last time, and they're like, no, you didn't say that. They're hearing it for the very first time, basically. So if nothing else, this way of engaging with patients can help the salience of it, especially if there are some cognitive challenges or with depression on board, like just helping the person to put, even in very few words, that just makes it a little bit stickier, what we're sharing. So I'd love to maybe work through one or more examples in basically what we've talked about here over not just this webinar, but also the previous two, around what are some of the client statements that you find challenging, or something that is making you pause and wonder, that we could use those tasks of motivational interviewing, some of the tools that we've shared, to diagnose or come to kind of how could you approach this in a little bit of a different way, or how might some of these approaches be helpful to you in getting through that roadblock. Saudia, you mentioned starting off that patient example around goal setting. Not, I promise not to put you on the spot, but can I ask, like, how is that helpful to you, or how do you think that you might use some of what we've talked about if you think that could be useful?
I think so. So, I mean, context around this too. So I did a little bit of the ask offer ask of like, so I just want you to, would you be interested in considering this? And, can I talk to you a bit more about this other factor that I think you should consider? And I planted the seed. It's still in the back of my mind that, this person should consider this, and it would make a considerable difference to their current function. But, again, respecting the person's autonomy, that, their goal is this particular thing that I can help with and that I can support. And it is my role to do that, but kind of planting the seed that you should probably also consider this. So they were accepting of another referral to deal with the other piece of things. So I felt like it was, a little bit of planting the seed, but that was sort of the helping, because it always comes back to like, that you can help them more.
Yes, of
But,
course, of
but
course. And
yeah.
yeah, and in that, like I heard you mention the referral, and it also strikes me that importance question might be interesting too when you see them. Like, how important is it to you to follow through on the referral, just on a scale of 0 to 10, and hear what they say, wondering if they actually will follow through on the referral.
And maybe they will, maybe they won't. But I think the for me, I think the factor, it was like, oh, I didn't think of it like that. That's a really good point. And that kind of helped me sort of, can I offer you a bit more about that? Or, do you think that's something that's really important to you? Yes, actually, that's something that I would consider. And then that's kind of where the discussion went. And then,
Excellent. Excellent.
it's good to, so focusing back on the goals that I can help with, this is, yeah.
That's awesome, because, and I think what comes through in just how you're talking about your client is how much you care. And that comes through, like, regardless of the tools and strategies that we use, that just that human caring, like, I am here in your best interests. I really want what's best for you. Like, that comes through loud and clear in just how you're talking about this person. So I'm sure, like, that goes a long way too. That's pretty amazing, Sadia. Thank you for that. Anyone else want to raise something or query something? Troubleshoot something?
And type in the chat if they want.
Yes. And I think just the kind of making sense of how what we've talked about maps onto your practice. I have some organizing questions that might help with that as well. Because it is the biggest challenge, the whole knowledge transfer field is organized around the challenge of bringing research into practice, knowledge mobilization into practice. And so that's what we're wrestling with here. And I'm really grateful for folks just, ruminating about how could this fit with your patients? Where are some of those sticking points that could use like just a little bit of a boost to move past that roadblock. So I have found that that staircase of the tasks of motivational interviewing a really helpful diagnostic tool to identify where we're stuck, where me and this patient are stuck together, because it helps me think about where am I relative to where the client is. Am I in planning when they're still in engaging or maybe even focusing? So how do I come back to that notion of walking alongside? And it's not like a straight line, as we talked about in the very first webinar, that sometimes we have to go up and down the stairs. It's recursive. So even if we've come up with a great plan, maybe some of those micro goals have been accomplished. And so now the replanning conversation is what's next? Like, what now? What else? Where else are we going to go? Or there may be a bit of a motivational roadblock on the part of the patient to actually follow through. And that's what re-evoking is for. Is this still what you want or need or choose to do? Let's have that conversation. Refocusing can be helpful for when the goal needs adjustment, not the commitment. So the commitment to the goal is what that evoking conversation is for. What all that time we spent last week on change talk, evoking change talk, responding to it, inviting it, strengthening it, amplifying it. That I can't say enough about the importance of that evoking conversation, even spending some time there, even if you don't think you need to. Like, you will hear when that person is ready to change. They're just going to start going ahead and doing it and potentially re-engaging.
So we have a couple of thoughts.
Awesome.
One is mine, and it's not very structured, or I just always think about driving. And I know working on inpatient for so many years, people want to drive again. And after stroke, it's not always possible, or there's steps they need to take. But they certainly don't want to hear it. And they think, well, I know how to drive, so I'm not sure why I couldn't go back to driving now. So think about that for a minute, but let's go to Sadia's comment first, and a helpful, challenging question. I just want to go or stay home or whatever. That's what's important to me. So I just want to discharge from hospital, or I just want to stay home, or
yeah,
that might be a challenging question.
So in a focusing conversation, which scenario do colleagues think that would fit in? And maybe I'll just flip back to that. Oh, for some reason.
Just say that again.
Like, remember the 3 focusing scenarios where there's a clear goal, like a specific, achievable, agreed upon goal, or where there's a good long-term goal, but no clear path. How do we get there? Or there's just this general angst and concern with no clear goal. Like, where of those 3, I just want to go home, or I don't want to get out of bed. I just want to stay in bed. Like,
that's the third one, right?
It could be the third one. It also, I mean, it sounds specific though. Like, I'm
Go
thinking
ahead, Sadia.
it's almost like I just want to go home. Yeah, Sadia, do you want to jump in?
I think it could be a bit about, like, I work in community, so it's a little bit different for me. So people want to stay home, but I also used to work on inpatient rehab, so they also wanted to go home. So I have both kind of examples, but I think it's a bit of 2 and a bit of 1, because sorry, 2 and 3, because for some people, it is a very clear goal. I just want to go home, and but what does that look like, or what can we do to get you there? But they're not safe to go home. I think the biggest thing that we always come across is whether or not someone is safe. And there's a lot of education, or if there's a medical issue that's underlying this, that we can't really navigate. And there's a level of safety or independence, or they can't do it independently. I want to do it by myself, but there's so the level of safety, I think, is maybe the challenging part of helping them understand that maybe they're not independent with this, and they may need to consider additional support, or things like that, or vice versa. They don't want to go home and they are independent. I'm just kind of thinking out loud. So
Yeah, definitely. And so thinking about that bubble sheet as potentially one tool that could be used in terms of what specific target areas would you like to focus in on that will help get you home? Or that provide, elicit, ask, offer, ask conversation about what's your understanding about what would it take in order for you to be discharged safely. Can I offer some thoughts about this? What do you make of that? How does that fit for you? Like, if either of those could help, and then if it's a little bit of that third, then some of those other questions about what would this look like for you, getting home safely, being able to be sort of functional at home now.
Sarah also mentioned the opposite in the chat. So patient says, I don't want to go home. I want to stay in hospital.
I was going to
Functionally, they're
say,
ready for discharge, but do not want to participate in their self-care activities.
yeah, yeah. And in fact, I was a little surprised that there's like the wanting to go home, because there's probably as many or more people that are like, no, I do not want to go home. Like this, like for fear, or knowing that it may not be as comfortable, or maybe their home situation or environment is a difficult one. So yes, absolutely.
We have another example from Brooke. She used some of the MI techniques with the patient who shared she knew it was important to wear her leg brace, but wasn't doing it. In listening to her, it became clear that she had the automatic negative thought, people will think I look like an idiot when they look at me. I ended up using some ACT and CBT tools to delve deeper and challenge this thought. But do you have any suggestions of how you might have addressed this thought from an MI approach?
It sounds like you addressed it beautifully. I guess if I were to add, is how could some of those motivational tools, like that spirit of MI, which it sounds like was already present in how you engaged with them, just that curiosity to want to learn more about what's underneath that. It's not just resistance and non-compliance, and to have the courage and care and compassion to have that deeper conversation about and for the level of trust to be there for the patient to have expressed that. I think that the ORS tools, specifically reflective listening, can be just an incredibly helpful complement to those conversations in an efficient way of even getting faster further to what are some of those underlying reasons. But love how you handle. I mean, it sounds like that's just good that's just good care. Thank you. Right back at you, Brooke. I'm just looking. Oh, and I saw Krista said, I'm going to buy that 4th edition book. That's awesome. It is so worth it. Like, I will say, you will. And the other thing is, it is such a good read. It doesn't read like a really boring textbook. It reads like a helpful practitioner talking to you about the most relevant issues that you deal with your patients and in your life. Like, it is just the tone of it is so accessible and respectful and interesting too, with lots of clinical examples. So I really highly recommend. And I saw Steve, thank you for the post-stroke checklist observation around the transitional care. So I'm glad that resonated. I'm looking at, are there other?
Just so looking, Terry and I think we'll put together a handout that includes all your yellow starred slides.
Okay.
We'll
nice.
Piece them into one handout, and then we'll send that off to all the registrants so they have quick access to it.
That's lovely. That's so nice. You're amazing, Sue. You're very amazing. Okay, we're going to get to the start fresh each time. And I just wanted to make sure I got all of the comments. And the reluctance to hope and their situation for years. Yes. And so Dr. Miller talks about how just good listening, like deep listening, unconditional acceptance, that in itself can be curative and important, and not to underestimate that. And I really appreciate how, despite decades of quite stellar, like thousands of RCTs and research studies on motivational interviewing, meta-analyses, funded research trials, like there is still this humility about it of like at its core, the real magic of this approach is about just how to be a good practitioner. And that's why I think it is so complementary with other approaches that colleagues may be using. I'm going to share my slides again, and let's look through some of these other, as we're sort of transitioning to some of the ways that we could use this in practice. So this is the kind of wrap up part as we're heading in the next 15 or 20 minutes to the end of our third webinar. And these are real dim sum dumplings, and I ate them and they were delicious. And the bright colors were from natural vegetable dyes. It's like they look like candy, but they're not candy. They were yummy. Anyway, key takeaways. So some questions for reflection around the time that we've spent together that may help bridge that knowledge mobilization gap around just taking a minute. We talk to clients sometimes about journaling, that taking a minute and maybe journaling some of your thoughts about this that you may even put aside and come back to next month or next week or who knows when, or come across it when you're moving your office or cleaning out your file drawer. But that in itself can make it more salient for you, the time that you've invested together. So something that you've learned or relearned or gained, something you appreciated about the time that we've spent together, something that surprised you, or something you wanted more about and could maybe dig into even further. Ways that you could use motivational interviewing with your patients, and maybe some areas that you're feeling more confident about, and something or several things that you can't wait to try. So that's a little sort of transitional tool that is not to be underestimated, because I learn what I believe as I hear myself speak, that you, putting it in your own words, and writing it down actually can help mobilize your own practice. And so let's talk about continuing practice in motivational interviewing. So all of the star slides, actually, I've put it all here on this one thing. So I guess if there was one thing you printed out, and maybe write yes, but on a Post-it note and put it on your desk, is this practice tip sheet, which really covers the nuggets that we've discussed, including some of the things that you could say, and just putting some language around some of the strategies and approaches. And remember the spirit, the essential foundation. I think I can't emphasize that enough, that the skills fall flat without the spirit of motivational interviewing. So this is the centering reflection that Christo is asking about. How do we start fresh each time? So Bill Miller, in addition to being an emeritus professor at the University of New Mexico in Albuquerque and quite a celebrated celebrity psychologist, anytime Bill Miller is like speaking at a conference, there will be standing room only, and has actually done a couple of podcasts. And in fact, Sue, I'll send you a link to a really cool podcast that it's about an hour long, and it's quite engaging, where Bill Miller is reflecting on this new edition of motivational interviewing. But based in New Mexico, and has done a lot of work with Indigenous communities and peoples in New Mexico. He is also a minister, and he calls it a motivational interviewing prayer. I think of it as a centering reflection in a more secular way, but I think all of this is powerful. But those first few lines, for me, are incredibly powerful in centering myself before a conversation with a patient, especially one where with that client, my fixing reflex just automatically gets activated. Like I see their name in my calendar and it gets activated. Guide me to be a patient companion, to listen with a heart as open as the sky, and grant me vision to see through their eyes, that accurate empathy, and eager ears to hear their story. Create a safe and open mesa or place. I've never been to New Mexico, on which we may walk together. And I think, the other piece around the honoring and respecting of their choosing of their own path, and bless them to walk it freely. May I know once again that although they and I are different, yet there is a peaceful place where we are one. We're all human. We all have these struggles related to change. We all have good days and less good days, and we all go through difficulty and pain and sorrow and trauma, as well as joy. And so I think coming from that human perspective, that eagerness to hear, that curiosity, that open mindset, that putting it being in service to is a really powerful way. So did I put a start? My screen is, can't see if I put it in the start. Yes, I did. That this might be the other one in addition to yes, but, that if you wanted to print something out and just highlight some of the phrases in there that resonate for you as a way to come to that conversation with that person in that moment as if they were the most important person in your world. That's a gift. And if there's nothing else that you remember from these webinars, that just bringing that gift of yourself to each and every encounter is itself so powerful and precious. So continuing to develop, I'm not going to read it all here out loud. You have it in the slides, but here are some peer supervision and coaching tips. Motivational interviewing is really big on observed practice and recording sessions and discussing them after and coding them. So I don't know if that's something that, if there is currently a community of practice, or, if you have like a clinical buddy that you work with, or a little friend group that you work with, but maybe that's something to consider in like a Zoom lunch talk that that you could continue in your own micro community of practicing some of the skills. And having a little snippet of a conversation actually is more helpful than kind of retroactively trying to remember how much change talk or your own reflections or how many questions you asked, because we are on the wrong side of our eyeballs. We can't see our behaviors. So that it removes that bias, and that objectivity will actually really help you hone if you're interested in developing the skills. So the community of practice is a really great idea. A helpful practice activity is a good real play, like in motivational interviewing, not a role play, but a real play where you and a colleague can switch roles, and one person talks about their list of priorities for the next 3 months. So what are your actual priorities for the next 3 months? And your colleague, their goal is to clarify goals. They're not going to evoke, they're not going to fix, they're not going to tell you what's right or wrong. You're going to come to an understanding of what those goals are just based on that short conversation. And the debriefing is around what you found helpful in how your colleague engaged you in talking about your goals. That will give you some insight into how you come across to your patients. So those kinds of real plays, maybe it's a real play just focused on something that you're thinking of changing, and then your colleague interviews you using those 4 questions in the homework. And then you have a chance to reflect on, like, how many questions were there? How many reflections? Maybe you agree to record it and then go back and listen to it. And I've found to be a really safe and low threshold way to practice the skills that doesn't feel as heart-stopping as I'm going to record 15 minutes of my client session. Like, that can feel a bit intrusive. And there may be some permission and obviously patient information safeguards that you would need to put around that. A little bit more on evoking. And so here is some additional insight into change talk and sustained talk, and why it matters. And a little bit more on planning. And we talk about ask, offer, ask. We talk about, just elaborating on that, testing the water if that person is ready to plan, offering a summary. The key question, where do you think you'll go from here, can be a helpful way to identify if that person is really ready to, or do we need to do a little more evoking, more change talk. And then this is, in plain language, just some motivational interviewing practice targets. So if you were part of a randomized controlled trial and you were in the motivational interviewing clinician arm of the study, then your sessions would be recorded and coded using the MIT or some of the different MI validated coding tools. In effect, this is what the coders would be looking for. Does the clinicians do less talking than their client? That's a good gauge of how much change talk or I learn what I believe as I hear myself speak conversation your client is giving you. So that's, I think, a helpful guideline. On average, 2 reflections for each question. And when you reflect, going below the iceberg, those complex reflections, and avoid getting ahead of your client's level of readiness. So what they would call non-MI adherent things would be like warning or giving uninvited advice. You can give advice, but you have to ask permission. And then that makes it MI adherent. And I want to just add that, of course, with any client population, but specifically in stroke rehab, as we've been discussing and have reflected some of the research around that, that our clients are best guides. You and your patient will determine the best way to proceed. So as we wrap up, I hope that this has been a bit of a curated tasting menu, that you have a few recipes to try out at home and at work. It's been such a pleasure. I've really enjoyed our time together. And I want to end with this quote from Andy Warhol, which I think is just so amazing for not just motivational interviewing, but change in general. That when people want to change, they like, you can't make them do it. Sometimes they die before they get around to it. You can't make them change if they don't want to, just like when they do want to, you can't stop them. And to me, that encapsulates the impact of spending a little bit of time practicing these tools and bringing them forward with clients and patients. So with that, I guess in honor of Valentine's Day, we have some hearts on the screen. So I'm going to stop sharing. Thank you, and hand it back to Sue to wrap us up.
Great, thank you. I'm just going to do the ending poll.
Yes. So this will be where we really see how motivated you're feeling after our 3 webinars. How motivated are you to learn more about MI and apply what you've learned to your clinical practice? Highly motivated, somewhat motivated, or not really very motivated or interested? So let's see where you're at. And wherever you're at is 100% fine, because remember planting seeds, right? Sometimes the season is not right. And then when the season comes, it's amazing what that little seed can blossom into. So let's see where we're at. Awesome. I love that 61% are highly motivated and I'm actually surprised and heartened. I don't know if that was just because you're being really nice to me that no one answered the third one, but I'll take it. Thank you for that. I'm delighted to hear that. And it's been such an honor to engage with such expert clinicians in an area that, I'm not an expert in stroke rehab. So thank you for your patience and support through this and sharing some of your own clinical experiences. You've made it just such a pleasure. So thank you. And thank you, Sue, for inviting me.
Yeah, thank you, Marilyn. I appreciate it. I've put the evaluation up on the screen. So Terry, if you can type it into the chat for people, they can click on the link or you can use the QR code and just give us a little feedback on the series, the whole 3 sessions. It doesn't take very long. It's only 6 or 7 quick questions. And I'll share the results with Marilyn when I have them.
Thank you. And those trainings, I can't emphasize enough, often people don't do the evaluation, and we need the evaluation. It would be very helpful for me and my feedback as well. And Sue, I know that that's one of your deliverables and metrics. So you're helping your colleague Sue as well by just taking a minute and doing that evaluation.
Yeah. So we will put together the yellow star slides and send that out as a handout. We will also send people a certificate of attendance so they can put that in their files of something they attended. For myself, there's a few things I'm thinking about in follow-up to this. One is, do we need the book? And I'm going to think about that and take a look at the book and see if it's helpful to have a hard copy of that around. And number two, there it is there. Yeah. Fourth edition, reminder, fourth edition. And the other thing is, do we need a follow-up session at some point that is a little bit more practice? Just something I'm thinking about. I'm developing my new education plan for this coming year. And so if people could talk about that in their evaluation comments of if that would be helpful, go back, think about what you've learned, maybe practice it a little bit with a colleague, maybe try it with a patient or two. And then maybe we do a little follow-up session at some point that's
or a teenager or a loved one. That's a good place to practice too.
Yeah, I need to practice on my husband, just saying.
There you go. There you go. Me too.
So something that we're thinking about. And Marilyn, thank you. You've been a great speaker. We didn't know each other. We took a chance. You really incorporated stroke care into it, and I appreciate that. Not everybody that joined today is working in stroke care, but they work across the Northeast. So we're thankful that they could join us as well. I hope people find it helpful. I thought it was excellent. You're easy to listen to. You're easy to understand. You're engaging. So you've got a lot of great qualities for doing this type of work. I can see why you're so invested in it. So we really appreciate that you shared your knowledge with us over the past 3 sessions, and maybe we'll look forward to another session in the future.
Love to. Thank you again. And if anyone wants to email me a picture of the ice fishing place where there's the street signs or ice huts, I would love to see them.
Okay, well, I'm going to look for that for you.
Get that out there. Okay, well, have a wonderful rest of your week. Thank you again, Sue, and thank you, colleagues, for joining. And we'll be in touch, Sue. I'll look forward to seeing the evaluations and happy to help and support in any way I can.
Great. Thanks very much. I'm going to stop the recording.